One number to start. In BRAF V600E-positive iodine-refractory thyroid cancer, adding a BRAF MEK inhibitor more than tripled progression-free survival from 3.7 months to 12.8. The first phase 3 evidence for genotype-directed therapy in this setting. Let's get into it. Welcome to the Head and Neck Oncology Journal Club. I am Krishna Kumar Thankapan. In each episode, we take one paper that should change or at least challenge how we practice, and we work through what it actually shows and where it stops short. Today's paper is from Lancet Oncology, published online on the 13th of July 2026. The first author is Ming Gao and the senior author Lori Wirth. It's a global, randomized, double-blind, placebo-controlled phase 3 trial of Dabrafenib plus Trametinib in radioactive-refractory BRAF V600E-positive differentiated thyroid cancer. Why this question matters? Let me set the clinical scene, because the value of this trial is really about a gap it fills. Most differentiated thyroid cancer does well, but roughly 15% of the patients becomes radioactive iodine refractory, and once they do, prognosis drops sharply. Our first-line systemic options in that setting are the multi-kinase inhibitors, lenvatinib with a median progression-free survival around 18 months, and sorafenib around 11 months. The problem is that the resistance is essentially inevitable, and then we are into the second line. Until now, the only second-line options with phase 3 backing has been cabozantinib from Cosmic 311 trial. The median progression-free survival of about 11 months, but an overall response rate of only 11%. So the second-line bar in terms of tumor shrinkage has been low. Now here's the biology that makes today's paper interesting. BRAF V600E is a genuine driver in papillary thyroid carcinoma, present in something like 35 to 60% of the cases in high-income countries and about 75% in East Asia. It switches on MAPK pathway constitutively, and that same signaling is part of why these tumors lose iodine avidity in the first place. We already have Dabrafenib plus Trametinib approved across a range of BRAF V600E driven cancers, namely melanoma, non-small cell lung cancer, glioma, and anaplastic thyroid cancer. There were promising phase 2 signals in differentiated thyroid cancers, but there had never been a phase 3 trial in this specific population, and that is the gap. So the design. This is a phase 3 trial across 42 sites in 11 countries. They enrolled 153 adults with locally advanced or metastatic radioactive iodine-refractory differentiated thyroid cancer, all papillary histology, who had progressed after 1 or 2 prior VEGFR-targeted therapies with ECOG performance status of 2 or better. Crucially, BRAF V600E status was confirmed centrally by real-time PCR, not just locally. Patients were randomized into 2:1 Dabrafenib 150 mg twice daily plus Trametinib 2 mg once daily versus matching placebo. So 101 patients in the combination arm, 52 on placebo. Randomization was stratified by the number of prior VEGFR therapies and by prior lenvatinib exposure. The primary endpoint was progression-free survival by blinded independent central review in all randomized patients. Secondary endpoints were overall response rate, overall survival, duration of response, and safety, including Trametinib specific concern of serious retinopathy. 2 design points worth holding on to. First, placebo patients whose disease progressed on central review were allowed to cross over to the open label Dabrafenib plus Trametinib, and most of them did. Keep that in mind when we get into the survival. Second, this trial was actually designed before cabozantinib and lenvatinib plus pembrolizumab became available second line. So the comparator here is placebo, not the active second line therapy. Who was in the trial? Quick word on the population because it matters for how we read this. Mean age was 62, 86% of the patients were Asian, and 50%, that is half the entire trial, were from mainland China. Only 12% were Caucasians. Every patient had papillary thyroid cancer. Most had received one prior VEGFR therapy, and the rest had two. Coming to the results, the median follow-up was 17.4 months, the primary endpoint first. The median progression-free survival was 12.8 months with Dabrafenib plus Trametinib against 3.7 months on placebo. The stratified hazard ratio was 0.38, 95% confidence interval 0.25 to 0.57, p less than 0.0001. So a 62% reduction in the risk of progression or death. And notice the placebo arm underperformed even the trial's on assumption. They had modeled 5 months and got 3.7, which tells you something about how aggressive this refractory previously treated disease is. Overall response rate. This is where the contrast is great. 57% in combination arm versus 4% on placebo. A 53% point difference. And that response was the real depth, not just minor shrinkage. 6% complete responses and 51% partial responses. On placebo, that 4% was literally one complete and one partial response out of the 52. Disease control was 88% versus 63%. Overall survival. And here is where we need to be careful. This was a pre-planned interim analysis. Median overall survival was not reached in the combination arm versus 25.9 months on the placebo. Hazard ratio 0.66, but the p equals 0.083. So it did not cross the significance threshold. Before anyone reads that as a negative survival signal, it is not. This interim was done at 46 deaths, which is only 56% of the 82 deaths expected by the end of the study, giving it roughly 16% power. And 30 placebo patients crossed over to the active drug. So the overall survival comparison is both immature and heavily confounded by design. We simply cannot conclude anything about survival yet. Results about safety. Onto the safety, median exposure was much longer in the treatment arm, 14.5 months versus 5.5, which you have to keep in mind when comparing adverse event rates, because more time on the drug means more time to accumulate toxicity. The most common adverse events were the ones we would predict for this combination. Pyrexia in 48% and anemia in 45%. Pyrexia, as ever with the Dabrafenib plus Trametinib, was a signature toxicity, and it was managed mostly with dose interruptions and antipyretics. Serious adverse events occurred in 43% of the combination arm versus 25% on the placebo, the commonest being pneumonia at 8%, which was also the most frequent grade 3 or worse event. Serious retinopathy, the Trametinib specific ocular event was seen in 7% and none on placebo. On treatment deaths were 17% versus 6%, but most of these were disease-related rather than treatment-related. 10% of the combination arm died of thyroid cancer itself. There was one death from a cerebrovascular accident that the investigators judged related to the study drug. Discontinuation for the adverse effects were low and comparable, 8% versus 6%. The author's overall conclusion on safety is that there were no new signals related to other approved indications of this combination, and I think that's fair. Now about the limitations. First, the generalizability. Half the trial was from mainland China. That's not a criticism of the science, but we do have to ask how directly this transfers to the general world population. Second, and related, nearly a third of this combination arm had prior anaemia, a multikinase inhibitor that is available only in China. So the treatment history of this cohort is not the treatment history most of us are working with. Third, the survival data are immature and underpowered, as we discussed, with a substantial crossover. Final overall survival is pending 3-year follow-up. Fourth, and this is a big pragmatic one, the comparator is placebo, not the active second-line therapy. This trial does not tell us how Dabrafenib plus Trametinib stacks up against Cabozantinib or against Lenvatinib plus Pembrolizumab. There is a head-to-head trial against Cabozantinib ongoing, but is not expected until 2030. And finally, they did not report papillary variant or TERT promoter mutation status, both of which shape prognosis in disease. So coming to the bottom line, for a patient with BRAF V600E-positive radioactive iodine-refractory differentiated thyroid cancer who has progressed on one or two VEGFR-targeted therapy, this is the first phase 3 evidence that a BRAF MEK inhibitor combination works and works well. More than tripling of the median progression survival, a 57% response rate against essential nothing on placebo, and a toxicity profile we already know how to manage. What it does not yet gives us is a survival readout or a comparison against the other second-line agents we actually have. So my practical take, there is a strong argument for genotype-directed second-line therapy and a strong argument for making sure we know BRAF status of these tumors, because that molecular result now has a clear therapeutic consequence. Whether it becomes the preferred second-line option over Cabozantinib is a question the head-to-head trial will have to answer. That is episode 20. The paper is Gao and colleagues in Lancet Oncology. The link and the full write-up are in the show notes and the newsletter. If this was useful, share it with a colleague who manages thyroid cancer. I am Krishna Kumar Thankapan. Until next time. Thank you.